somehow. That's why we have lots of backup. So I'm going to share my screen and take you through just a few slides that I've put together to try and take through some of the issues that I think that might be of interest to you. People might know that we are doing a couple of consultations with the health department team next Tuesday afternoon, and so I wanted to make sure that people had had a chance to sort of understand what you're likely to be consulted on, and a few things perhaps if you're interested, which many, and I also want to acknowledge the huge amount of wisdom and experience that there is in this group. So undoubtedly, once we go through the slides, there'll be lots of opportunities for people to share everything they know, in addition to what you've already shared, just as you were logging, just as you were checking in there. So I'll make the screen a bit bigger. So what we decided to do today is we wanted to try and just give you a bit of an overview about what Health Consumers Council knows about the work that's being done as part of the Sustainable Health Review with regards to culture and workforce. And so there are 5 recommendations in the Sustainable Health Review that relate to that. The consultations that I mentioned next week relate to recommendation 26, and I'll talk about that later. But I wanted to give you a bit of an overview of what we know about all of the work, because as with all of the Sustainable Health Review, they're all so interlinked that it's quite hard just to think about one thing and separately from the others. So people would have heard me acknowledge country to start with, but just to do it again, that we are meeting on here where I put my feet on the ground is the country of the Whadjuk people of the Noongar Nation. And I pay my respects to elders past, present and into the future, and acknowledge that people have that group have occupied and cared for this country over countless generations, and we celebrate their continuing contribution to the life of this region. I'd also like to take a moment, this is something we learned through the work of the Mental Health Commission, but to recognise lived experience, and many of you have that and you've shared that as some of the introductions, that we recognise the importance of lived experience perspectives at the table when planning health services and reforms, and recognise the value that they bring as we design, deliver and evaluate our health services. And I know that I'm speaking to the converted there, I would think, with this group. But I thank you for continuing to bring yourselves to these tables. For anyone who didn't know about Health Consumers Council, I think many of you do, we are been around for about 28 years, so we're starting to plan our big 3-0. And our vision is of equitable, person-centred, quality healthcare for all Western Australians. And we see our purpose is about increasing the capacity of everyone to influence the future direction of healthcare and to make informed choices for themselves and their families. And we have 3 teams that do that. We have an individual advocacy team, an engagement team this is the part of the team that we're in, and systemic advocacy. And that together, all of those teams learn about the experiences of individual people, support individual people to get the care and support that they want and need, and then also advocate for system issues across the whole of the health system by engaging with people in the community. Now, I think there is someone who I might just invite them to ensure that they're muted, because I think there's just a little bit of background noise. So today we're going to do, the aim is to raise awareness of the work that's underway under workforce and culture under the Sustainable Health Review. From now on, I'm probably going to call that the SHR, it's just a bit quicker. Highlight some background information that might be helpful as you consider this area, to encourage you to participate in the consultation opportunities that come up, but also to give space where consumers and community members can ask questions about this work. So I do need to, though, give you a big health warning that this information session has been initiated by us. We're trying to demystify this work stream and empower people to be active partners in the work. So what you'll see me present is not communication that's been approved by the Department of Health. Whoops. So very briefly, I think you all know, because you're quite an informed group, that the Sustainable Health Review was released on the 10th of April in 2019, which, you know, who knew, that's over 3 years ago now. It includes over 30 recommendations, and they're organised into those 8 enduring strategies that you can see on the screen, and I'm not going to go through them all, but it's fair to say, from where our stance is, it covers almost every aspect of health in Western Australia. And while it took a bit for work to get started in earnest. So there was a bit of a delay getting started while, you know, the health department largely reorganized itself to be able to deal with such a significant reform program. And then, as we know, along came COVID, so that put a lot of the work on pause as well. But now we're starting to see some more momentum generally across all of the reform programs, and we'll continue to keep you updated about those as much as we can. But we are going to focus on the Enduring Strategy 7, which is there about culture and workforce to support new models of care. So there's a lot of words on this page, and I'm not going to read every one of them. You will get sent the slides afterwards, but suffice to say that recommendation 23 is about building a system-wide culture of courage, innovation and accountability. So there's a really strong focus there, recognizing that culture is a big part of high-performing organizations. Also recognizing that the WA Health system, what we would refer to WA Health being the state health department and the health service providers, so North Metro, South Metro, Child and Adolescent Health, WACS and East Metro, but noting that they need to work as a cohesive, joined up system, but is always so outward looking that works in partnership across sectors. That there are contemporary workforce roles and scopes of practice. So for example, looking elsewhere, both in Australia and internationally, to see what opportunities are there for workforce roles and to be different. And there is some work happening in that space, which I'll touch on very briefly. Recommendation 26, which is the recommendation that we'll be doing the consultations on next Tuesday afternoon, and that's about building capability in workforce planning and formally partnering with universities, vocational training institutes and professional colleges to shape the skills and curriculum to develop the health and social care workforce of the future. And again, we've got a bit more detail on that later. And then recommendation 27, which is about removing barriers to equity, flexibility and transparency in workforce arrangements. Now, what I've tried to capture here is what we know about the consumer involvement that has taken place in this work already. So with regard to recommendation 23 about the culture of courage. So first of all, I should say all of these workforce recommendations presented to the Sustainable Health Review Partnership Forum. Now that is a forum made up of community service providers for non-government organisations, but also some lived experience representatives are at that table too. So all of them presented to that group in November last year. We in fact reached out to this recommendation team earlier this year because given the work that at Health Consumers Council we're keen to progress around consumer leadership, we wanted to make sure that there's an opportunity to align that and perhaps partner with the work that's happening on staff leadership. So I know that there has been some, that work was paused when we reached out, but I think it might be getting started again. I'm not aware of any other work that's happening on the cohesive outward looking system, but that doesn't mean it's not happening. It just means that it hasn't come across our desk at the moment. Contemporary workforce roles, there is a consultation underway at the moment, and Health Consumers Council was approached to be part of that, and we took part in an interview with the consultant doing that work, and we think the potential opportunities for that are particularly ensuring that new roles such as care navigators or peer workers are considered as part of that programme. Workforce capability is the one that we've got the consultation on next week. And equity in workforce, again, I don't know much about that, but it doesn't mean it's not happening. As I understand it, one of the particular things is whether or not there's an opportunity for a standard learning management system, so LMS, across all health service providers, so that, for example, if somebody has undertaken some online training for one of the health service providers, that accreditation or acknowledgement is able to be carried across if they work for another health service provider, rather than them having to do the work again. But like I say, just because we're not across some of the detail doesn't mean it's not happening. It just means that it hasn't crossed our desk in a way that has enabled us to comment on it. Now, what I'm thinking So I'm going to go through this slide and then I might pause because I can see there's been some things in the chat. So I'm just going to pause and see if people got questions as we go. So when I was bringing a consumer lens to this, based on a lot of the conversations with many of you that we've had already and from other consultations that we've been part of, these were just some of the issues that started to, that I think might be of interest as we look at this. So first up, and we already heard it when people were checking in there, consumer and carer involvement in training and development of healthcare roles and professionals. So both helping to advise on the curriculum, but also in actually delivering the training. And I know a number of you have, I know a number of consumers, and perhaps some of you have already been directly involved in that. Another thing that comes up very regularly, almost every consumer conversation I have ever been part of, and I've been in this health system here in Western Australia for 16 years now, is this question of care navigation and helping people to experience more joined up care across a system that is a bit fragmented. The other thing though is this question about transition roles, and this is something that came up in our consumer rep networking event just yesterday afternoon. That could be, for example, roles to support people to transition from child to adult services. It could also be to transition from rural to metro and back to rural services. It could be from hospital to community services and so on. But those roles that join the system up rather than, I remember I heard it once described as many health systems, not specifically in Western Australia, but many health systems are, you know, there's a sea of services and there's great practice. There's these points of great practice, but then the consumer has to swim from one point to the other. And that kind of bridge between those bits of the systems are not always there. So I think there is something about what workforce issues can help support with that. Another thing that with regards to when you think about value-based care or you think about improving the safety and quality, what we know generally about making improvements is that psychological safety, where you feel safe to speak up and safe to make a mistake and learn from a mistake, is really important in terms of continually improving and implementing innovations. And those are known to be important for safe, high quality care and what are known as high reliability systems. High reliability systems are systems that you know will work time and time again. I think that there's an opportunity, and again, we've been doing some work around the question of value-based care. There was a conference in Perth last year looking at what value-based care might mean from a consumer point of view. And I think that there are opportunities for consumers to understand what measures are being measured that contribute to a sense of psychological safety. So, for example, we know that in the Minister for Health's employment staff survey, which the last one was last August, there were a couple of indicators in there that suggested that not like only 1 in 2 people feel like it's encouraged to speak up and do something, you know, speak up about something that needs to change, and only 1 in 2 people feel that if somebody makes a mistake that they are taken care of, that they're treated fairly. And those are a couple of indicators that I think are important for community members to be concerned with when regarding workforce. The other thing that comes up, and again, this is work that's come up in a number of topic areas, most recently, I guess, for me in the area of the work that we're doing around weight and health, is the importance of a relational approach to services. So that is, well, yes, you're dealing with a system, but at the end of the day, that care relationship is often between a consumer or a patient or a client and another health professional or a group of health professionals. And that is a human to human, person to person service. So even if those services, and Deb mentioned in the introduction about moving to more digital health, even where those services are being delivered digitally or remotely, how do we maintain that focus on the relationality of care? Another thing that has come up, and again, when we've asked people what makes a good experience, very often the examples that they talk about are where somebody has had the time to be present with them. It can sometimes be a concerning time to be in a healthcare setting, but people often talk about having somebody who had the time to be with them and help reassure them and help them get the care that they needed. So again, how from a workforce point of view, when there's pressure on health system, when there's high demand for health systems, how do we as consumers speak up for making sure that time is protected for staff to free them up to care and be present with people as they need it in healthcare settings. There's also the opportunity to consider these new roles. So that goes to that point before about the care navigation that go across traditional workforce silos. From what I understand of Aboriginal health workers, that is the sort of role that can help people navigate from one part of the system to another. Care navigators are also roles which are being explored, and I've got a couple of links that I can share with you later. And then finally, and again, a number of these things overlap, this need for roles that can deal with health and social care needs. So recognizing the non-clinical aspects that impact on health. Now, I'm going to take a pause there, and I'll pause the recording just to see if... Okay, so now I want to give a bit of an overview of some examples and ideas just to bring them into your awareness. And again, at the end, because I know of the levels of expertise and knowledge that there is in this group, there'll be plenty of others that you can share too. So in summary, I guess I just wanted, people might have heard that phrase, culture eats strategy for breakfast, and the importance of organizational culture on the experience that people have. There's a book called Radical Help, which if you've heard me talk on this sort of stuff before, I spoke it all the time, but the essence there is the question of co-design in workforce models and how important that is. We're going to touch briefly on some information about peer workers, Aboriginal health workers and bicultural workers, touch briefly on social prescribing, and one of the examples of that, which is Mending Health Connections, which is in the UK. Another example being from New South Wales, which is a programme called Beating Diabetes Together, touching on the role of nurse practitioners and other advanced practice roles, and care navigators and linker roles. And like I say, there'll possibly be more text than is comfortable on these slides, but I was writing them with the intention of them being shared afterwards. So this is one of those busy slides. I guess this, for me, that question about, you know, and it was one of the business thinkers who said, culture eats strategy for breakfast. And so you can have an excellent strategy, but if your organizational culture isn't such that you're going to be able to deliver on that strategy, then the focus really needs to be on the organizational culture. Now, in the UK, there's some work coming out of the UK King's Fund on compassionate leadership. And the reason I had a look at this is because we know that when we ask consumers, or when people talk unprompted, unquestioned about what it is that they want from a health system, compassion and kindness is something that is often mentioned. So there's some research via the King's Fund there that says there is clear evidence that compassionate leadership results in more engaged and motivated staff with high levels of well-being, which in return results in high quality care. And I've included the link there so that you can go and dig into that a little bit more if it's of interest. As I mentioned earlier in that summary of the points that a consumer lens might bring, I think it's fair that we would say there's some room for improvement in Western Australia at the moment. Last August, only 45% of staff agreed that they think it's safe to speak up and challenge the way things are done in their organisation. And only 52% of staff agreed that their organisation treats staff who are involved in an error, near miss or incident fairly. Now, of course, we don't want there to be errors, but that does happen. And organisations, in fact, the term psychological safety came from an examination of healthcare settings where they were considering two teams, one which seemed to be a high-performing team and another that was perhaps less well-performing, but the high-performing team had a higher level of incidents being reported. And the researcher was very curious about that and thought, I need to dig into that more. And actually, what the researcher learned was that there weren't necessarily more incidents happening in that first team, but there was more reporting of the evidence of the incidents. So because it was safer to report them so that they could be caught and improved for the next time. Whereas in another team where that level of safety isn't there, then some things might go unmissed because people are like, well, I'm not mentioning that. Because it doesn't feel safe or encouraged. So that's why I think that this is a really important one for consumers and consumer reps as yourself involved in all the various ways that you are. Again, it's very small. I don't expect you to be able to read that writing on the screen, but I just wanted to touch on the King's Fund have a whole section on the 4 behaviours of compassionate leadership. And one of them is attending, so being present with and focusing on others. The other one is understanding, so taking time to properly explore and understand the situation someone is in. Empathizing, so mirroring and feeling colleagues' distress so that you can, but in a way that you yourself don't become overwhelmed. And then helping. And I just think that there's so much potential, and it's such a critical part of safe, high quality care, that I think it is of importance to consumers. But there's links there if you agree and you want to have a little bit more of a look. Radical Help, this is a book that I heartily recommend if you are interested in how we can improve our health and social care systems. Then it's a relatively easy read. It's very inspiring. I'm sorry that image is a bit grainy, but you can buy it from any good bookstore. One of the things I like here is I've put a link to a blog in there. What is the role of the modern state in creating the good life? So this is important, I think, given that many of our health services, not all at all, but many are delivered as public services. Are the public servants of today simply humanisers of the inevitable, those who must mop up the fallout of rapid techno-economic change? Or can we be the radical architects of a much needed social revolution? And I don't know about anyone else, but I certainly feel pretty inspired with that. And I think, you know, the public service as radical architects of a social revolution, that sounds great to me. I wanted to also include this case study. So Hilary Cottam works with local governments and public sectors in the UK predominantly, but not only. And she has given an example quite relevant to the health setting, obviously. I work with people like Anne. Anne is unwell and in pain and overweight. She keeping appointments with 9 specialist doctors is her full-time job. But when I meet the doctors, they tell me something Anne already knows. The drugs don't work. Anne needs radical help to change the way she lives. I set up in doctors' surgeries and ask them to send me heart sink patients like Anne. Now that's not that's not an idea of what Hilary Cottam thinks of those patients, but rather how they may sometimes be referred to. A small team then starts to unpick the always complex problems that lie behind ill health. Anne decides to take up her embroidery again. Her mood lifts and she's ready for the next challenge. The remedies are unorthodox, more often social than clinical, but the data impresses the clinicians and the service cost is low. So I think, again, that's, and I think that's something that's worth having a look at if you're looking for some inspiration and ideas, because she does talk about many examples that she's actually been able to implement radically different approaches. And just to touch briefly on this question of peer workers, Aboriginal health workers, bicultural workers. So these are all roles that exist in some parts of the system or in some parts of Australia. So peer workers, they're pretty well embedded in mental health and alcohol and other drug services. And there is some work happening at a national and state level to try and support mental health and alcohol and other drug peer workforce, and to set up a lived experience workforce association. The Consumers Health Forum, so the National Consumers Health Forum, got together a group of consumer leaders across Australia and brought them together in a consumer commission, and they found that there is a need to enhance the role of peer support across the mental health and suicide prevention systems, as peer workers are currently sporadically utilised and poorly supported. And we think at Health Consumers Council that there's an opportunity to explore extending these sorts of roles into other conditions. So we've been doing some work, and I know many of you have been involved in it around, it's called the Wake Education and Lifestyle Leadership Collaborative. And again, just last week, a group of consumers came together and said, you know what we need? We need a peer mechanism, a peer support group where people can come along and be met by people who have similar experiences and understand where they're coming from. I've included the link there at the bottom left, to the Consumer Health Forum link. I also wanted to bring into people's awareness, and again, I know others on this call will know much more about this than I do, but registered Aboriginal and Torres Strait Islander health practitioners and health workers are qualified to perform a broad range of responsibilities. They provide culturally safe support in a variety of settings and have access to MBS item numbers. And I think that, I had a quick look online, I think there's about 270 members of the National Association for Aboriginal Health Workers and Practitioners in Western Australia. And I would be curious to understand if there would be a value in more, and what are some of the issues with regards to that. The other issue is bicultural workers. And again, this isn't an area I know a lot about, but there is certainly in New South Wales, I think I've included a link there from a group called Co-Health, who have a fair bit of information about the opportunities to use bicultural workers or for bicultural workers to play a part in improving health in communities. And again, if you look online, you see a fair bit about how some areas have had great success in working with bicultural workers, particularly in the area in the time of COVID. And as it says there, bicultural workers use their cultural knowledge, language skills, and lived experience and community connections to work with people who they share a lived experience with and with mainstream organisations. And again, I think with these opportunities, peer workers, Aboriginal health workers and practitioners, bicultural workers, what you're seeing, I think, is the opportunity for some of those to be those bridging roles, to sort of be alongside people. Social prescribing, so many people will know about this, but if you don't, social prescribing recognises that many things that contribute to our health are social and not just clinical. It started in the UK, and I'll show you the example of that in a second, when a GP recognised that a lot of people who were coming in to see her, the things that actually were going to help make the difference as to the real improvements in their health were social, not just clinical. And so they've got a whole programme, and I've got a really short video that I'm going to show you on the next slide. In Australia, there are some examples. For example, here in Western Australia, we do have compassionate communities, and we have them starting all over the place. So I heard just this morning of one that's starting in Kalamunda. We have them, I think there's one starting to be looked at in Yanchep. We have them in the southwest. We have them in Albany. So these are, again, communities coming together to provide that social support that supplements clinical care that people might need. And compassionate communities have a bit of a focus on end of life and grieving. So it might be people who are living with a life-limiting condition, or it could be people who are grieving the loss of someone. But again, it's about that community support. Other examples around the country, you've got Live Well Tasmania and Live Well Logan in Queensland. And what you see there is a real integration of a whole suite of programs. It might be, growing your own vegetables. It might be embroidery classes. It might be walking groups. But these are, again, that integration between the clinical aspects of health and the social aspects of health. I do think as consumers that we might have a question, I know I certainly do, about whether or not it has to be called social prescribing. I feel like maybe that's medicalizing something that maybe doesn't need to be medicalized, but I also know that that might be a lever for change in terms of it working alongside clinical professions and or doctors. So I think that's an interesting question. So I wanted to, there is a little video. Now, I don't know if I've installed it, but I will try and get it lined up. So basically, Mending Health Connections started in the southwest of England. It started in the GP surgery, and the process that they followed is, first of all, they get community members and service providers together to map what do we already know that exists in the community. That's a very kind of interactive activity. Then from that, you say, okay, so that's what we've got. What do we need? What is there not that we would like? And then you take action collectively, the community and service providers together, to take action to address the gaps. There's a couple of key workforce roles that are part of that. You've got community connectors. Now, these are members of the community who act as volunteers, but they're trained to signpost people to relevant services. And then you've also got health connectors, and these are staff members who work one-to-one with people who need that integration with different parts of the health system. So what I might do is I might keep going, and then if we have a bit of time, I'll come back and show the video. Another example here in Australia, not Western Australia, but in Western Sydney, is the Beating Diabetes Together programme. So this is a combination between the Primary Health Network in Western Sydney, so it's called Went West, and they work in partnership with their Western Sydney Local Health District. So that would be the equivalent, for example, if we had a West Metro Health Service, which we don't, it would be the equivalent of our West Perth PHN working with our West Metro Health Service. In Western Australia, the situation, as you might know, with primary health networks is slightly different. We have 3 primary health networks and the 4 health services, but that, you know, basically it's a partnership between the primary care sector and the hospital sector. And then it says there is also an alliance of over 130 partner organisations. And what they know is they know that that area has a high number of people who have diabetes. And what they wanted to do was to see how they could take the heat out of that hotspot in Western Sydney. The idea being to help both prevent and manage diabetes so that it makes it everyone's business and people's health and experience are improved. One of the fascinating things I thought is, and this is just a snapshot from their website, one of the most significant initiatives of the Western Sydney Diabetes has been the introduction of HbA1c screening, which is a screening that is done to ascertain about diabetes. So they've introduced that screening at 2 emergency departments, and over the past 3 years, more than 100,000 patients have had an HbA1 screening performed as part of a regular blood test. And so now they're also rolling this out into some general practices. And the idea is that early screening promotes early detection and pre-diabetes, and so those can be better managed by the consumers and their health teams working together. We've only got a couple more slides and I will put pausing again. So nurse practitioners and other advanced practice roles. So nurse practitioners have been in Australia for over 20 years, but I think it's fair to say that they're perhaps not as widely used in the community in Australia generally as they are perhaps in, for example, the UK and elsewhere. So a nurse practitioner is a highly experienced registered nurse who's completed master's level study and has been endorsed by the relevant board. They can prescribe some medications and do some advanced procedures. And there are over 2,200 nurse practitioners in Australia. The Consumers Health Forum found that there is strong support from community for nurse practitioners. There is a study that looked at the effectiveness and compared the people's experiences and outcomes with nurse practitioners versus a doctor. And one thing that stood out for me was the comment that one of the studies found that patients are more satisfied with care from a nurse practitioner than from a doctor, with no difference in health outcomes. But it's important that more people are aware of the scope of nurse practitioners. And I think if it's something that you as a community feel is important, that there is community calls for it more. Because at the moment, MBS items, so that's how primary care is funded. You go along to the doctor and they claim an item on the Medicare benefit schedule, so MBS. The fact is there's only specific items that a nurse practitioner can be funded through, and so that can act as a barrier to access. Nurse practitioners at the moment are the only health professionals required to establish a collaborative arrangement. So at the moment, from a clinical practice point of view, nurse practitioners have to have a collaborative arrangement with the doctor. And that there is some information in the health paper there from the health department about the workforce, the nurse practitioner 10-year plan consultation that highlighted that that does perhaps have an effect on the power balance between nurse practitioners and doctors. And it's worth also noting that the RACGP do not support independent nurse practitioners, and I've included the link there so that you can acquaint yourself with that if that's something that's important. But there are other possibilities too, for example, advanced practice physios or advanced practice dietitians who again do further study and therefore become qualified to do more advanced care. Care navigators, I think many of you will know about these. There's a couple of papers there, I won't go into a lot of detail, but the Consumer Commission report from the Consumer Health Forum, and then they also did one specifically focused on rural and regional people. So both of those reports found, and I've bolded there, that certainly for the country it was suggested patient liaison coordinators are needed for people from rural, regional and remote communities. And there's a suggestion in that second paper, the one with the green cover, to develop a national vocational qualification in healthcare coordination that incorporates peer workers and or patient liaison roles, as well as advocating for and coordinating care specifically for rural, regional and remote patients. And I know that Robert, you had shared with us something yesterday about some work that we know is already happening in WA. So perhaps in the discussion, it would be great to hear a bit more about that. The other thing I wanted to touch on are link roles. And again, I'm not going to read everything on this, but there's a lot of work out there looking at link roles. This is work from the Paul Ramsey Foundation, who identified that the people who would benefit the most from support are consistently the ones who are missing out. So as you can see in the top right-hand circle there, people often carry trauma or their distress from the sharp edges, from their experience of the sharp edges of the service system, whereas linkers have an opportunity in linking different bits of the system and softening those sharp edges. And again, I think I have included the link. Yeah, so the link's there at the bottom, the Paul Ramsey Foundation link. But what you've got there is stuff, again, which would be very familiar to you as consumer reps: navigation, flexibility, client-led, relationship building, and embedded in the community. So I'm going to pause again before I then touch briefly, don't worry, very briefly, on recommendation. In fact, I'm going to keep going. I'll keep going with recommendation 26, and then we'll pause and have a discussion. So recommendation 26 is the one that we'll be doing the consultation on next week. It's about building capability in workforce planning, partnering with universities, training institutes and colleges to shape the skills and curriculum to develop the health and social care workforce of the future. These are the implementation priorities. And again, because of time, I won't read through them all, but the one in bold is the one that we are going to be looking at next Tuesday, a 10-year health and social care workforce strategy, which was to be developed by July 2021, when those days in 2019, when we didn't know COVID was coming. That's now anticipated to be late 2022, early 23 for the strategy to be developed. And that's going to be looking at joint planning of training needs and placements, an interdisciplinary approach to care, making sure that people get training in both acute and community settings, and that there are placements in metro and regional areas. Again, this will be gone through at the consultation, and we'll go through the slides, but these are the themes that have started to emerge already. Lots of them we've just talked about: culture and engagement, healthcare leadership, workforce planning, which is trying to, again, understand the likely workforce needs in the future. Looking at the workforce interdependencies. So again, what are the other things that are impacting on the recruitment and appointment of particular roles? That relationship with social care, continuing to build capability and skill development. And again, this has come from the team. So the Aboriginal, Torres Strait Islander, and culturally and linguistically diverse workforce, and noting the the particular importance and efforts in that area. Very briefly, the other one in the Sustainable Health Review that I think you all know about is recommendation 4, and I'm delighted to say that the Health Consumers Council Executive Director is the co-lead for this recommendation. So we're really continuing to champion consumer partnership in all of the work of the Sustainable Health Review. I think you already all know about this, but I'll just leave it up there for anyone that's looking at it afterwards, that if you're coming to this and you're not already involved in a group, there are lots of opportunities to be involved as a lived experience person or a consumer or community member in helping to drive positive change across the health system, including some national opportunities. I've included those there too. And so, to sum up, 2 consultation sessions happening next Tuesday afternoon. 1 p.m. is the session with the regional focus. We particularly want to give space for that conversation to happen. And at 4:30, there's a session with a metro focus. They're both entirely online because of COVID right now. But if, for example, you're not able to make it to any of those, then you can also email the team directly, and we'll put these links in the email that we send out to you afterwards. So I'm going to stop there now, and looking forward to the discussion.